I'm Brett Klein with Eisenhower Health here at the Marketing and Public Relations Department. Welcome to our kickoff for the season, it seems like, for Cardiovascular Institute lectures. And just a couple of housekeeping things before we get started. We are recording, and you got that notice. So this will be recorded, it will be edited, and then it will be posted on our Eisenhower Health website, along with our YouTube channel within a week and a half, if not sooner. And then we'll also, if you registered for this, we will also send it out to you via email to let you know that the link is active. And then in the process, please go ahead and use the chat feature to ask any questions as you go along. We will try to hold all the questions till the end. So I will work as your voice to ask the questions of the doctor during the presentation. That way we don't interrupt the recording. And then what we'll do, we'll open it up at the end for live Q&A from the members and people who are joining. With that in mind, I'm going to turn it over to Sheena Fernandez, who is going to introduce herself and then also introduce Dr. Sharma as our speaker for tonight. We're adding more people. So Sheena, it's all yours.
All right. Thank you, Brett. This is Sheena Fernandez, Director of Cardiac Services, and it is my pleasure to introduce Dr. Dinesh Sharma, our newest member of Desert Cardiology, and he is our newest structural interventional cardiologist. He is board certified in internal medicine, cardiology, and interventional cardiology. Both of Dr. Sharma's parents are nurses, which influenced his decision to pursue medicine as a vocation. I love that. And he tries to envision each patient as a family member and discusses issues with them as if they were an aunt or uncle. He completed a residency program in internal medicine at Case Western Reserve Metro Health Medical Center in Cleveland, Ohio, continued at Case Western Reserve University, where he completed a fellowship in cardiovascular disease. He then completed 2 additional fellowship programs, interventional cardiology at Beaumont Hospital in Royal Oak, Michigan, and structural cardiology at Buffalo General Medical Center, University of Buffalo, New York. So without further ado, I will let Dr. Sharma take it away here. Thank you so much, Dr. Sharma.
Thank you, Sheena. Thank you for that introduction. So I was just going to start off by talking about prevention of heart disease. Like, as of right now, I think we live in a world that has a lot of advancing technology. I myself do stenting procedures and valve procedures, and I feel like every year or so there's a new procedure that comes out, or a new technology or new implants that come out, and it's very fascinating. But today I want to mostly focus on prevention of heart disease and how it can't be overstated. The importance of it is very significant these days. So just a funny slide there that I added. So what is heart disease? So just starting off with the heart, it is a very hardworking organ that pumps about 4 to 5 liters of blood every minute during rest, more so during stress and exercise, and it supplies nutrients through blood to the rest of the body and itself. So when it squeezes, it's pumping out blood to the rest of the body, and then when it relaxes, it's actually filling in these 2 coronary vessels that you see across the screen here, the right and the left, and then the left bifurcates into two main branches. So these are the 3 main vessels that we are going to be talking about. So they surround the heart, they keep it nourished, and they mostly provide the heart with blood flow when the heart relaxes. So every beat is so important, right? So during contraction, or when you think of the heart squeezing, it's providing to the rest of the body, and when it's relaxing, it's providing to itself. So what is coronary artery disease? Over time, what happens is fatty deposits, which begin in about the 2nd decade of life, called plaque, build up within the arterial walls. The artery, as you can see in this picture, becomes a bit more narrow, and that is called the atherosclerosis. When this becomes more than more than a significant amount, and we can talk about the exact amount later. It's called coronary artery disease, when it's actually flow limiting to the rest of the heart. Okay. A little bit about the timeline here. So although you can develop foam cells, which are underneath the endothelial surface that react and form these fatty streaks, usually around after the age of 20 is when you'll notice these small fatty streaks from cholesterol and plaque buildup that occur. After that, what you can see on this timeline is the buildup of this fatty streak into what seems like an intermediate lesion and then an atheroma. And then what happens after that is what you hear about the most is the plaque buildup. When you're in the office and one of the cardiologists is speaking about plaque buildup, you see it in this stage here. What you don't want to see is a complicated lesion or a rupture of this plaque buildup. That's when you see that, that's when you hear about heart attacks that come to the hospital in an ambulance that need to be emergently treated. So we try to stabilize that plaque as much as possible. Are other organs affected? Yes. So when the heart is affected, in essence, the brain can be affected as well, and as well as your legs and feet, just because they develop those same vessels, and those same vessels can be diseased just as if though your heart was going to be diseased in those previous slides that I showed. Symptoms. So symptoms can be pretty typical or atypical in nature. The typical symptoms that we look out for when you are chest pain, right? When you hear about the elephant sitting on your chest, worsening with exertion and getting better with rest. But what's scary about this is that you don't have symptoms for a long time. With that plaque buildup, you can get up to 50, 60% disease, or even more. You can have blockages that are up to 50 or 60% without any symptoms at all. And those blockages can sometimes not even be detected by a stress test when they're around that 50 to 60% blockage. So this is something that you do have to look out for when you do have chest pain for a short amount of time that's with exertion and relieved with rest. It's called angina. And then when you have it severely, when you hear about people having severe heart attacks that cause muscle death in the hearts, and heart failure, which is what happens when you have shortness of breath and leg swelling and irregular heartbeats, and of course the worst symptoms is sudden death. Those 30% of people that have major heart attacks that don't make it to the hospital. Sorry, we're starting off a little morbid, and then we'll talk about what we can do for prevention. So how big is the problem? It is the #1 killer in the disease worldwide. It's 12 million deaths annually. That is increasing. The good news is in developed countries, there is a rising health awareness of this and government programs to try to decrease this incidence. But what's alarming is in developing countries, it is increasing, just because and we'll talk about why. So you may come to the office and wonder, why is it me? Why did I develop this cholesterol buildup or this heart disease? And we're going to talk about things you can kind of control and things you can't really control. Things that you can't control is genetic predisposition, right? The way that your body handles cholesterol, the way that your body handles plaque buildup, as well as the poor handling of fats and metabolic syndrome. And then, of course, where we live now, we live in an area. And when I say we, I speak about just America. We live in an area of abundance. I would say that the easiest things to buy and the easiest things to eat are the most unhealthiest in essence. So whenever we're hungry, there's always a McDonald's or an In-N-Out burger right around the corner. And although they're delicious, they're unfortunately the worst things for us. And it's been getting worse over the past two decades or so. A small McDonald's fry has gone from I think 10 ounces to probably double that, and it increased in just about 400 calories. And is that okay if you? Sure, that's okay if you walk 2.5 hours a day, and that's what it'll take to burn off those 400 calories. But the abundance that we have and the sudden change in lifestyle to sedentariness, where we can just drive from one place to the other, that is part of the problem that's happening to us. So this is kind of a more talk about what things we can't help and the things that we can, and which we'll touch upon further. So age, we can't really help that. Our genders, our races, and our family history, what's been given to us, right? And then the things that we can help, which we'll talk about, is high cholesterol, smoking, blood pressure, diabetes, obesity, alcohol, and physical inactivity. So how important is cholesterol as far as being a modifiable risk factor for a patient attributable risk percentage? And that's what that PAR is at the bottom of the screen, is patient attributable risk and lifestyle factors. So I'm looking across the top, and the most modifiable risk factor is cholesterol. And after that becomes smoking. So cholesterol is actually more modifiable than smoking. And then what's important here that isn't stated enough as well is the psychosocial aspect, being happy, doing things that you enjoy. So that also falls up there in the top 3. Abdominal obesity is up there next, and then hypertension, fruits and vegetables, more so the lack of fruits and vegetables in our diet. Exercise, diabetes, and alcohol is on the list as well. And we'll talk about all these. So cholesterol, everybody needs cholesterol, right? A lot of my patients come up to me and say, well, what if my cholesterol is too low? Well, and we'll talk about the numbers that are healthy as well, but this cholesterol circulates in the blood, and our goal is to get it low, especially if you've had an event like a heart attack or a stroke in the past. You can't get your cholesterol low enough. The guidelines every 5 or so years, the guidelines become more and more strict of getting that cholesterol level lower and lower. Currently, it's at 70 for the bad cholesterol, and we'll talk about that more in detail. But it's going in the next few years, it'll become more strict than that as well. So too much cholesterol can deposit in the arteries and form that plaque, and then block them. And the scary part about this is no symptoms till you actually have the heart attack. That being said, I'd also like to say that it's not only chest pain. It's not that typical left-sided, somebody sitting on my chest. That's what it feels like. As we know in diabetics and women, the signs can be completely atypical. They can be shortness of breath, or they can be no chest pain at all and just jaw pain. I had a patient that just had pain between their shoulder blades and their back, and that manifested as what was a small heart attack that they were having. Now, does that mean everybody with back pain should be worried about a heart attack? No, but the things we should look out for is consistency with the exertion and relief with that rest. And always talk to his physician. Getting an appointment is quite easy. Getting in and talking and just being at ease with some of the workup. So where does it come from? Where does this cholesterol come from? 35% of it is what we eat, and 65% of it is actually what your liver can produce and other cells throughout your body. So that's also important. A lot of the sources of cholesterol come from animal fats and meat products. So the good and the bad, right? The LDL is what we hear about all the time. It's the bad cholesterol. It has a tendency to increase the risk of heart disease. It's a major component of the plaque and what can clog up your arteries. HDL is actually the opposite. It's a protector. The good cholesterol actually helps carry away some of that bad cholesterol away. And how do we increase our HDL? It's inherently higher in women, and it increases with exercise. And when I say exercise, not necessarily lifting weights, but more so cardiovascular activity like walking or anything that gets your heart rate up, swimming, the elliptical, things like that, and biking. So obesity, I'll just touch upon this just for a second, that obesity confers you to have a higher risk, 2 to 6 times the risk of developing heart disease. And what's interesting, something that I didn't know about, is where is that obesity stored? Is it in or near your hips and your legs? If that is the case, it's further away from your organs. You're actually at a less of a risk than when it's around your chest or your abdomen, where it's around the organs. So slightly higher risk. So physical inactivity is the new smoking. basically what is recommended by the American Heart Association and what we should be doing. We should be active about 5 to 7 days of the week, and we'll talk about that as well. Cigarette smoking, it does everything bad that we had mentioned in the past. It increases the blood pressure, it decreases our good cholesterol, it damages our vessels, increases heart attacks, and what we should know is that cigarette smoke contains more than 4,000 chemicals. 200 of these chemicals are poisonous. I'd like to touch a little bit upon, and I didn't put it in my slide sets, vaping. Vaping is a new thing that kids are doing, or teens, as well as people that are coming off of smoking. It can be just as dangerous as smoking, if not more. Just recently, it's become regulated by the government. Before then, there was no regulation of how much nicotine could be in there. It could be 20 times the amount of a pack of cigarettes. And there was no regulation as to what is in the vaping product. There was metals that could be in the vaping product that you're smoking, and that's why you see there's been case reports around the entire nation with kids developing vaping associated lung injuries and being intubated in the hospitals after they had vaped things that they had no idea what was in them. Like non-pure forms of fentanyl could be in this vaping, things of the sort that. So when we think about vaping and think about it as a bridge off of smoking, it's actually much worse. It can become it can be much worse as far as addiction and the chemicals that are contained in the vaping. Diabetes, of course, dangerous because diabetics have a 2 to 3 fold higher increase of heart attack or stroke of the same person without diabetes. 80% of diabetics do die from heart disease, and the risk of sudden death from a heart attack for a diabetic is the same of somebody that already has had a heart attack, or has had stenting, or has had a stroke. So your risk factor automatically goes up. So sorry about all that morbidness that I had to talk about. Now we can talk about how do we prevent all this. Look before you eat, right? So just look at your plate. If there's a bunch of colors on there, that's usually good. Vegetables and fruits. They take up a lot of space. They make you feel full sooner, and they're overall just more healthy to eat. You can also switch to fat-free milk, skim milk. That's a small step that you could do that would also help you out in the long run. Choose non-fat or low-fat products. Complex carbs when it comes to eating a variety of grain products is important as well. Lean meats when it comes to chicken, fish, we'll also talk about that. So American Heart Association says walk, and then walk some more. 30 to 45 minutes, 5 to 7 days a week. This really cannot be understated as well. Just there's a lot of exercises in the gym that we'll talk about that hurt your joints, and they're not always comfortable. Walking is the one thing that you can do that you can continue doing and is easy to maintain, because this is all about lifestyle changes, right? And just whatever you can do for the longest amount of time. So what else? It also increases your HDL, which we talked about before, and it lowers your LDL and total cholesterol. So it's basically a pill that you take every day, and by walking that 30 minutes, it can help you avoid people like me. So just more about that exercise. The mortality is halved in retired men who walk more than 2 miles every day, and regular exercise can decrease the risk of heart disease as well, particularly men who walk briskly. Now, when I do say walk, I don't think you need to have a high intensity of your walking. You don't have to have weighted anklets on or anything. It just has to be moderate intensity for that 30 to 45 minutes. Let's see here. So, and then this is the same thing, just talking about 30 to 45 minutes and how people say that, and myself included, sometimes I get home and I don't want to walk. It's something that my wife and I are working on, just making sure that we do at least get that 20 to 30 minutes and then eventually 30 to 45 minutes, and how important that is. Yeah, this is just just walk. No, there's a lot of complicated exercise machines and sweating it out in the gym is not essential. It's good to do just for the variety and the fun and the community involvement that comes with the gym, but walking is just as effective. Of course, stopping smoking, that needs to happen immediately to help reduce that. Within 24 hours of quitting smoking, your risk of heart attack starts decreasing. Within 1 year, your risk decreases significantly, and within 2 years, you're about at the level of a non-smoker. Your smell and your taste improve right away, and within 3 months of quitting, your smoker's cough usually disappears. So that's also what I tell my patients. I tell them that the first 3 months are going to be pretty miserable because all of your lungs have basically been hibernating, and all the cilia in your lungs have been taking a nap, and now all of a sudden they're awake. You stop smoking, and you're going to feel like you have pneumonia because you're just coughing up loads and loads of sputum, and you're going to say, well, I never felt like this when I was smoking. And that mostly is just due to the cells in your lungs just being dormant at that time and not getting rid of anything. But once you get over that 3 month, that hump that you have to get over, I feel like then you do start feeling better, is what I let them know, that it's not easy. It's not an easy feat those first 3 months. I just really like this cartoon because he's prescribing a patch, but he's telling him to put it over the patient's mouth. So our benefits, of course, go beyond heart disease. They go to weight control, cancers, respiratory illnesses, getting that exercise and getting your lungs moving. Osteoporosis actually improves with it, oral health, mental health. So now we're going to talk a little bit more about your numbers. And getting that cholesterol down below 200, and then your LDL below 100, and we want your good cholesterol to be as high as it can possibly be. I think the highest I've seen for an HDL is around 114, and your triglycerides below 200. Well, what happens when your HDL is high, that good cholesterol actually takes away one of your risk factors. So if you do have like diabetes and obesity and an HDL of 100, you had those two risk factors, it kind of erases one of them. It's strange how that works, but it's a very protective effect. So, and then the ways to get that up is exercise. So reducing cholesterol, a 10% reduction of blood cholesterol produces a 20 to 30% decline in cardiovascular deaths or related deaths. People that are above 20 years old should get tested with their primary care physician. And if it's elevated, then you work on goals of getting that lowered. I just a brief slide about blood pressure. Our goal is, and it fluctuates every decade, but right now my goal for my patients is below 130 over 80. It's also a silent killer. Think of blood pressure as your heart pushing up against something that you don't really know about. If your blood pressure is elevated, it's like your heart is working against and pushing like against a Mack truck or something, where we really want it to push against like a Prius. So, and then there's several foods that help decrease blood pressure. I think I put a link on it at the end of my presentation here. But they do involve greens, bananas actually help, and spinach and things of the sort. They kind of go back to that colorful plate that you look at. These are just some interesting studies that I found just for lightheartedness, and but they were studied, and there were some trials on it. Children actually increase your risk of cardiovascular disease. So when you have the yellow line is 0, as you can, the yellow bar here is 0. Having 1 to 2 increases it, and then 3+ actually increases it more when it comes to the number of children that you have. Pets actually decrease your risk significantly. When it comes to dogs and cats, and when you separate them, this is what I tell my friends as well, that dogs significantly reduce your cardiovascular risk, whereas in cats slightly increase it. I'm sure some of my friends don't like that. So, and then there was another study that showed that the effect of, so these are heart failure patients with class 1 and 2 over here with in the dark line, and this is class 3 and 4. 1 and 2 is basically heart failure patients without symptoms that can go on with their regular activity. And then the class 3 and 4 are patients that become short of breath with just mild to moderate activity. And then that correlates very well with the marital quality. A good marriage can lead you, and this is actually your months from assessment and the proportion of people that are alive after 4 years, and much more in that low heart failure class, and much more alive in a good marriage, whereas in a bad marriage can have that same effect on you. So increased cardiovascular risk. Stay happy and choose the right person. So my conclusions. So we should be very strict about our cholesterol. It's the one thing we can control from the age of 20 on. Always go in and check in with your PCP as well as your cardiologist and talk about ways that you want to get it down either naturally with over-the-counter supplements or just statins as well as several other medications that are coming out now when it comes to injectables. Eat complex carbs and eat less. It's hard to do with what we talked a little bit about abundance and how much food there is available, but something that I like to practice or at least preach. Don't smoke. On an everyday basis, we should be physically active. Do something enjoyable because mental health and staying happy is just as important as we saw on that graph is number 3 on the list of modifiable risk factors. Everything in moderation when it comes to alcohol. I feel like there's a new study that comes out about every other year. One says that you can have 1 to 2 drinks of alcohol every week or so. The next one says 0 alcohol. So that fluctuates, and that also goes along with if you find it enjoyable. I tell my patients about 3 per week, and nothing more than that. But if it causes you to be a little more happier, then that also goes in with that holistic approach of being happy. Marry happily, have good friends, have lots of dogs, and fewer kids and cats. So thank you. If there's any questions, I can try to answer those.
Yeah, thank you so much, Doctor. Great presentation. We have a couple of questions, and then we can open it up for our community to ask live questions. The first one is, what treatment therapies do you perform to correct heart disease in the Cardiovascular Institute, such as stenting in the cath lab?
Yeah, so in the cath lab, usually that's when you see patients that are either coming into the office or in the hospital with that chest pain, and they've been kind of ruled in as a heart attack. We've done some diagnostic approaches, and the next step is, hey, we should really take a look at your plumbing, which is what I like to call those 3 vessels, and make sure that your pipes are open. Once we go in there, if there is a blockage that's more than 70%, what I usually, and my colleagues and I usually like to do is balloon first and open up that blockage and see what it's composed of when we use the balloon. And then we place a stent. First we place a wire, then a balloon, then a stent that looks like it's made of cobalt chromium. It looks like the spring in a pen. And we basically open up those blockages. There's other procedures that are done in the cath lab as well. And like I said, the advances in technology are amazing, and that provides us with ways to do more and more procedures every year, and it's exciting in a sense. So we also do valve replacements now with our CT surgery colleagues, and we can do them either open or we can do them through the legs. We do valve repairs as well, and we do occluders of left atrial appendages. These can all be performed in EP labs, in the OR, and in the cath lab. But mostly in the cath lab, our goal is to restore flow of those 3 vessels and make sure that our stenting does restore that flow to the other muscles of the heart.
Great, thank you. One of the other questions is back on the issue of issues. How forceful are you in consoling patients on these issues, or consoling or counseling patients on these issues?
I guess most of my office visits, I would say 80% of my office visit is mostly talking about what we can do, what we can't prevent, and what we can prevent. And I think that's important to empower our patients to do the right thing. I think 20% of what we do will help our patients, and all we can do is empower them and give them the information that they need for that the rest of that 80%, which is mostly self-driven and self-motivated care when it comes to exercise and eating and those things. So most of that is just empowering them to do what is right for them. And when you talk to patients about that, I feel like we are more so at ease when you have a little bit of control in that sense.
Great. Thank you. Now, this one's a longer one. It says, I enjoy interval training, but recently had a patient who had a heart attack with stent placed, and he was told by his cardiologist to avoid interval training and not let his HR get above 120. What is your thoughts on interval training and this kind of recommendation?
Well, it's hard to say that as a generalized approach, not getting your heart rate above 120. I generally am okay with the heart rate going above, like, I guess 220 minus the patient's age times 80%. But there may have been in that specific situation a reason for the heart rate not to go above 120. As far as interval training goes, if I have patients with heart failure, and if that interval training involves weights and afterload, increase afterload when patients do um, such things as bench presses or dumbbells. Sometimes that does increase their afterload, and sometimes I do advise them to stay away from interval training when it comes to weightlifting in certain subpopulations. And in other populations, when it comes to the heart rate, I would have to, I don't restrict them unless there's a reason to. Interval training seems to be very proactive and protective in a sense, so that in the sense that when they stop the interval training, their heart rate is a lot lower. They get faster recovery time, but it may have been a situation in a subpopulation that it just wasn't healthy for them.
Great, thank you. How will I know if I have a TIA? What are the symptoms and how do you feel the week after?
So if you have a TIA, I think you follow that fast poster board that you usually see. Things like having difficulty finding words, or maybe slurring of your speech, or unilateral facial droop. Things like that is what you really want to look out for. And that's what, and I think the logo says fast because you want to act quickly. You want, sometimes it's noticed by your family members sooner than it's noticed by you, and or anybody that's around you at that time. So if they notice it, I wouldn't take it lightly. I would go to the hospital. And TIAs, by definition, they usually resolve, and you can't find clinical evidence of them on imaging. So what you want to find a week later varies completely from patient to patient. A week later, you may still feel fatigued, or a week later you may be completely asymptomatic. This is something you want to discuss with your neurologist. As far as preventative care in the future, usually when you have a TIA, you automatically get placed on a statin, because it stabilizes any type of plaque buildup you may have, and most physicians place you on dual antiplatelet therapy with aspirin and Plavix to help prevent a stroke in the future. So you almost get treated as if though you've had that event, and now all of a sudden your LDL must be a lot lower, 70, and then soon 55. In Europe, I think the guidelines are 55 now for anybody that's had an event, and in America it's 70. But I believe that Europe does things, and we usually follow them 3 to 4 years after. So soon, I believe it'll be 55 as far as your bad cholesterol, that LDL. So how you'll feel is completely individualized a week later. Did that answer the question?
I believe so. We have a few more here.
Mhm.
I had a CABG9 weeks ago, and whoops, I moved, and recovering well. How concerned should I be with 60% blocked carotid artery that has not been addressed?
Did you say how long ago was that?
9 weeks ago. Yeah,
Okay.
CABG 9 weeks ago.
So that's wonderful that you're feeling better. The reason the reason that was not addressed is because it was likely not flow limiting. And I understand your concern of, well, I'm sitting on a 60% lesion. at the occurrence of any chest pain, should I be immediately going to the hospital? Well, you shouldn't be concerned because they did the right thing by not bypassing a 60% lesion. The reason being is if you're competing for flow, and if you have no flow limitation down that vessel and you create a bypass tract, then what happens is that you have two open vessels that are going to a part of your heart. And usually when that occurs, you cause competitive flow. And when you have competitive flow, the flow slows down. And one of those bypass grafts that was bypassed there may close on you. So because it's thinking, well, hey, you don't really need me. So when you don't need me, I'm just going to close down. And just like if you create an extra highway that nobody uses, it'll likely shut down. So, and there's been several studies and more recent studies that have shown that people live with 50 to 60% lesions or 50 to 60% blockages for decades. So it doesn't necessarily mean that that your 50 to 60% is going to progress to 70 to 80. You could live your whole life with that 50 to 60, especially if the other ones have been addressed and you're on the proper medications. Then that is okay.
All right. Are you going to be involved in Eisenhower's TAVR program?
Yes.
Fabulous. There's a quick answer. That's the best one. Here's a longer one. It says, I have been having tightness in my chest with playing pickleball. When it gets really uncomfortable, I immediately stop playing and the tightness eases. Could that be a TIA? I know we never know. I've recently moved from South Carolina where the summers are hot and humid. I've recently moved to South Carolina where the summers are hot and humid.
Absolutely. Those are classic symptoms with exertion and relieved by rest. That is something that I would want you to see a cardiologist for immediately. You can see your primary care first, but that does sound typical in nature when it comes to chest tightness and pain. And if it worsens or doesn't go away, then I'd advise going to the ER.
Yes, fantastic. All right, a couple more questions here. How do you partner with our cardiothoracic surgeons for the treatment of heart disease?
Oh, we have a very intimate relationship with them because they provide knowledge that is really unique in the sense that they do open up chests. They feel your heart. They put their hands on your heart, so they're able to have that feedback and that knowledge of anatomy that's unsurpassable in a sense. So when we do TAVRs, there's always CT surgery involved because there is no better person to know what that anatomy looks like and what it feels like than a cardiothoracic surgeon. So a TAVR is a transcatheter aortic valve replacement that usually occurs without opening your chest and going through your leg. It's becoming more increasingly popular, but we're doing it with our CT surgeons hand in hand. And I feel that is very beneficial. When it comes to the cath lab, when we do a coronary angiogram and there's very complex disease and it may involve all the vessels or a major vessel that contributes to a lot of area in the heart, what we do is we take our patients off the table and we have a heart team discussion. And that heart team involves the cardiothoracic surgeons, the cardiologists, and most importantly, the patient and their families. And we sit down, we talk about what is the best option for them and whether that be placing a bunch of stents or doing a bypass surgery. So we're in constant communication and we're all trying to give patients the most amount of information and let them make that informed decision as a team.
Great, thank you. Another question, is chest tightness and leg arm numbness more common on the left side of the body with regards to heart events?
Yes, it is, but I wouldn't rule chest tightness and right arm numbness out completely. If you have chest tightness and the right arm concomitantly, I would still have that checked out as well, especially if it's at the same time. But yes, you're right. Left side is more common.
Great, thank you. Another question is for our Mended Hearts group or from our Mended Hearts group. Said, what would you recommend for our Mended Hearts support group members to best follow their cardiovascular disease treatment? Any good insights there?
Um, I think the Mended Hearts group does a very good job of just forming this community as well, and continuing to be almost leaders in the community when it comes to cardiovascular care and providing examples by leading. I think that in itself helps them quite a bit. But annual visits with your cardiologist, or whether it be annual or every 6 months, is important to keep. Regardless, even if you're asymptomatic and doing well, I think it's really important to just make sure you follow up with your cardiologist. That and movement, always, whatever movement it may be, movement is very important, whether it be in the form of yoga, water aerobics, just moving around, bed exercises, or walking, as I've talked about over and over. But movement and follow-up visits, I think, are really important for our Mended Hearts group.
Great, thank you. All right. With that in mind, we have some more time, but those are all the questions I had in the chat. And if there's more questions for the chat, please feel free to do so. But if you'd like to open up your mic and ask a live question of the doctor, please feel free to do so now. Let's just be courteous of each other. Bill Stark.
Doctor, I'm Bill, and welcome to the desert here, and we will look forward to having you at a future time at our Mended Hearts meetings and give us a talk. Really, thank you for your comments about Mended Hearts too. We really appreciate it. So welcome to, and I guess that from what your answer is that you are going to be the fourth TAVR doctor. Is that correct?
Yes, the fourth. Yep.
All right, awesome.
And thank you for that invitation.
All right, who's next? Any other questions from those online? Feel free to unmute yourself and ask a question. Everybody's having lunch.
I'll ask another one of you. Many of us are on aspirins and blood thinners and that kind of stuff. Sometimes throw in a Plavix in there too, I suppose, somewhere. There's always a kind of a question as we go along, and we've been on these things for years and years and years. Do you really need aspirin? Do you really need a blood thinner? How do they work together, or how do they work differently? I guess that would be a better question. How do those two work differently?
Yeah, so that's a great question. Aspirin for most people with an event, a cardiovascular event, and a baby aspirin is usually needed indefinitely. Now, the Plavix, on the other hand, like you said, which is an inhibitor of ADP phosphorylation, and that is not needed. But I don't want to say it's not needed, generally speaking. In a lot of situations, when you've had a stent placed, or you've had revascularization in the form of a CABG or a stent, there down the line, about 1 to 2 years down the line, you should have a discussion with your physician about coming off the Plavix. I think of Plavix as a super aspirin, and I think of a baby aspirin and then a super aspirin, and that super aspirin is usually Plavix or Brilinta or Effient. Those are all they all work in the same family. But the one that you should think about and have that discussion with your physician is the Plavix. And unfortunately, it's an individualized answer when it comes to how many stents you've had, how well you do with the stents, how your body reacts to Plavix, and how long the stents are. It even comes down to what the diameter of the stents are and how safe it is for you to come off that Plavix. So it's different for everybody, but that discussion it needs to be had after a couple of years, or just 1 year in the most recent data.
All right.
Mm-hmm.
Let's see. Here's one. Sorry about that. We had a question. Go ahead.
Yeah, Dr. Sharma, I have a history of mitral valve repair, which was done about, 16, 17 years ago. And my cardiologist has a different opinion than my dentist as far as hygiene, dental hygiene is concerned, what I do to prepare for it. In other words, pre-med. The cardiologist says clindamycin, but the dentist says that there have been, how should I say this, studies or approaches that clindamycin is no longer advisable due, I think it is, to brain hemorrhaging or whatever, and he recommends not the clindamycin. What's your feeling on that?
I see. So when it comes to the particular of the antibiotic, I usually defer to the dentist. Which decision that I make is whether or not an antibiotic should be started before a dental procedure. And
Right.
for a mitral valve repair, I think you should have an antibiotic on board always. But when it comes to the actual antibiotic, I would usually defer to the dentist. Now, that being said, this cardiologist may be a lot more in tune with which antibiotic you should be on beforehand, or depending on your chart as well. So I can't say against clindamycin, but at the same time, I usually defer that to the dentist.
Thank you very much.
The decision I make is whether or not you should be on an antibiotic beforehand.
Okay, thank you.
Sorry, clear as mud there. Sorry.
No worries. Another question that came in via chat, and then we'll see. I'm new to the desert with an HMO insurance based in another city. Is it possible to see you on a self-pay basis? If so, how is that best arranged? I'm not sure about that.
I'm not sure either. I think if you call the office, they can arrange all that as far as the logistics of that go. But I think that would be okay. It would just be something kind of out of my realm of practice right now.
Absolutely. I think calling the office would be the best way. That way they'll be able to talk to you specifically about your insurance current and what you may need, and then also the self-pay options. All right. Other questions from the community at large? All right. Anything further from staff members or Sheena? I believe you're still on.
Nothing further from me, Brett, except for we are so happy to have Dr. Sharma and welcome him with open arms. Everyone has had very positive things to say so far. So thank you for choosing us, Dr. Sharma.
Well, thank you. Thank you.
Yes, welcome aboard. All right, with that in mind, as a reminder, this will be edited and will be out there in our community and online and at our Desert Cardiovascular page on the website, as well as our YouTube channel within the next probably 5 to 7 days, if not sooner. All right, everyone, be safe. Enjoy the a little bit cooler weather coming into this weekend. They said it was even going to be mid-70s as our high, which is strange to hear this early in the season, but we'll be happy if it comes. All right, thank you so much, and we'll be back next week, probably with another lecture, and keep looking at our Eisenhower website. Thank you.